In this video, we will learn about the fractures and dislocations around the shoulder girdle. The learning objectives are to have an overview of the basic anatomy and radiology around the shoulder girdle, aetiology and management of clavicular fractures, mechanism, pathoanatomy and treatment of traumatic and recurrent dislocation shoulder, a note on the fractures around the proximal humerus. The shoulder girdle is formed by three bones, the clavicle, the scapula, and the proximal humerus. It's formed by four joints. The sternoclavicular joint is formed by the articulation of the medial end of the clavicle with the manubrium sterni. The acromioclavicular joint is formed by the articulation of the lateral end clavicle with the acromion process of the scapula. Glenohumeral joint is formed by the articulation of the head of the humerus with the glenoid process of the scapula. The ventral surface of the scapula articulates with the thoracic cage to form a scapulothoracic articulation. Before we start with the specifics, a quick look at the basic radiological identities of the shoulder girdle. The sternoclavicular joint, the acromioclavicular joint, acromion, the superior angle of the scapula, the inferior angle of the scapula, the superior, the medial, and the lateral borders of the scapula, the spine of the scapula, and the tip and the base of the coracoid processes are marked here. Let's now start with the first section, clavicular fractures. A square accommodating the widest part of the clavicle adjacent to the sternoclavicular joint constitutes the medial end of the clavicle. A vertical line drawn along the medial border of the coracoid process demarcates the lateral end of the clavicle from the shaft. A quick recap of certain special features of the clavicle. It is the first bone to ossify, and it ossifies by membranous ossification. It's the only horizontally placed long bone, and it has two curvatures. The main function of the clavicle is to keep the shoulder lateral to the torso for more efficient upper limb functioning. It also helps in transmission of the weight of the limb to the sternum. A quick note on cleidocraniodysostosis or dysplasia. It's congenital absence of clavicle. It is an autosomal dominant condition where there is a defect in the membranous ossification. Here, the shoulder moves towards the midline. The shoulder deformity will not need any further treatment as the functionality is reasonably well preserved. Clavicle shaft commonly fractures at around the mid-third lateral third junction. Indirect injury is the usual mechanism for the fracture, like fall on an outstretched hand or a road traffic accident. Direct injuries like fall on the point of the shoulder results in the lateral end clavicle fractures. The usual complications associated with clavicular fractures are malunion, non-union, and sometimes an associated neurovascular injury, especially in a polytrauma setting. In this radiograph, you will see a moderately displaced fracture of the shaft of the clavicle, and here you'll see a significant displacement of the fracture fragments. Note the drooping of the shoulder. The drooping of the shoulder is the deformity produced in clavicle fractures. It's mostly contributed by the weight of the arm, pulling the lateral end downwards. Contribution of the muscles in causing the deformity is limited, although sternomastoid may be responsible for superior angulation of the medial fragment. Contrary to popular teaching, pectoralis major is unlikely to be responsible for the deformities as it arises from the medial half of the clavicle. Coming to treatment, most clavicular fractures are treated by conservative method, resting the arm in an arm pouch, and sometimes a clavicular collar is used. However, it is more cumbersome for the patient to wear. However, certain clavicular fractures need to be treated operatively, such as an open fracture due to risk of infection and non-union, fractures associated with neurovascular injuries and other bony injuries which might lead to shoulder girdle instability. Other indications are non-union and a significantly displaced fracture. The standard operative treatment for a clavicular fracture is an open reduction and internal fixation with plates and screws. Whether a clavicular fracture is treated operatively or non-operatively, patients should be advised about active elbow and hand movements and to maintain hygiene of the axilla. Other clavicular injuries such as sternoclavicular dislocation and acromioclavicular dislocation are not covered in MBBS curriculum. However, I would like to emphasize 2 points here. Firstly, the coracoclavicular ligament, which is formed by the medial conoid and the lateral trapezoid parts, is the key structure stabilizing the acromioclavicular joint. The magnitude of dislocation is proportional to the amount of disruption of these ligaments. The second point is about the sternoclavicular joint. Posterior dislocation of the sternoclavicular joint is a serious injury due to compression of the major vessels and the trachea. Let's now move on to the next section, shoulder dislocation. The glenohumeral joint is the most mobile joint in the human body, and it comes at the cost of stability of the joint. The dislocation of the shoulder is hence a common injury most often seen in the emergency room. Static stabilizers of the shoulder joint are the labrocapsular complex and the coracoacromial arch. Labrocapsular structures consist of the glenoid labrum that deepens the socket and forms a chalk block to the humeral head, and the glenohumeral ligaments supplement the function of the labrum. Coracoacromial arch is formed by the coracoid process, the coracoacromial ligament, and the coracoid process of the scapula. These offer restraint to the superior migration of the humeral head. Muscles constitute the dynamic stabilizers, and the key ones are the rotator cuff muscles formed by subscapularis attached to the lesser tuberosity, the supraspinatus, infraspinatus, and the teres minor muscles attached to the greater tuberosity from anterior to posterior in that order. The subscapularis arises from the costal surface of the scapula, the supraspinatus from the supraspinatus fossa, the infraspinatus from the infraspinatus fossa, and the teres minor from the upper part of the lateral border of the scapula. Boundaries of the quadrangular space are formed by the teres minor superiorly, the teres major inferiorly, long head of triceps medially, and the surgical neck of the humerus forms the lateral boundary. Axillary nerve accompanied by the posterior circumflex humeral artery pass through this intermuscular space. Shoulder dislocation can be grouped into two distinct classes, traumatic dislocations and recurrent shoulder dislocation or instability. Based on the direction of the dislocation, traumatic dislocation can either be anterior dislocation, where the humeral head lies in the subcoracoid location, which is the most common type, and posterior and inferior dislocations. Recurrent shoulder instability can either be unidirectional or a multidirectional instability. The mechanism of anterior shoulder dislocation is fall on an abducted and externally rotated arm. Bankart lesion, which is the avulsion of the glenoid labrum and damage to the adjacent bony rim, is a classical pathological finding of anterior dislocation. This may be associated with avulsion of the adjacent periosteal sleeve. Hill-Sachs lesion is a compression injury to the posterolateral aspect of the head of the humerus, and it happens due to its impact with the tough glenoid rim. These three lesions are together termed Bankart triad. Clinically, the arm is abducted and supported with the other hand. There is loss of shoulder contour, and the patient will be unable to touch the top of the opposite shoulder, and this is called Duga's test. Sensation over the regiment badge area needs to be checked to assess the axillary nerve functioning. On an X-ray, anterior location of the humeral head and the Hill-Sachs lesion may be noted. In this radiograph, the humeral head is in the subcoracoid location with the arm abducted and loss of shoulder prominence. Here, you will see an empty glenoid fossa with subcoracoid location of the humeral head, and there is a Hill-Sachs lesion. Once the shoulder is reduced, the Hill-Sachs lesion becomes more obvious. Coming to the management of anterior dislocation shoulder, the first step is pain relief with an appropriate IV analgesia. Local assessment includes examination of the axillary nerve and look for further fractures. A radiograph confirms the injury and the treatment is closed reduction and check X-rays. Rarely, an open reduction may be necessary, especially if it is associated with a humeral fracture. Common complications associated with anterior dislocation shoulder could be grouped into early complications like an axillary nerve injury. Late complication is a recurrent dislocation shoulder, especially if the first injury occurs early on in the life. Close reduction starts with an appropriate sedation or anesthesia in a supine position. The surgeon applies a longitudinal traction in the direction of the deformity, counter-traction from an assistant. In traditional Cocker's maneuver, which is popular amongst emergency doctors, the elbow is flexed to 90 degrees, the shoulder is adducted, externally rotated, and finally internally rotated to reduce the joint. This is confirmed by the Douglas test. This method is based on the presumption that the subscapularis is under spasm and needs to be stretched out to allow shoulder reduction. The arm is rested in an arm sling and a check X-ray is done. Because of an extensive maneuvering of the shoulder, there is an increased risk of soft tissue injuries, especially the subscapularis and the glenoidum labrum, which might increase the risk of recurrent subluxation. The other method, routinely done by orthopedic surgeons, is just maintain a longitudinal traction and gently toggle the shoulder. This puts the head back into the glenoid. The Douglas test is performed and the arm is rested in an arm sling. With this method, there is no increase in the risk of labral injuries. We can also use this method to reduce the posterior dislocation and inferior dislocations. A few key points about posterior and inferior dislocations. Posterior dislocation is more common after violent muscle contractions such as an epilepsy or an electric shock. Because of this mode of injury, possibility of a bilateral dislocation should be suspected. Posterior dislocation is more often associated with proximal humeral fractures, and the standard treatment is as mentioned earlier. Inferior dislocations are rare and it happens due to a fall on an hyperabducted arm. Because the humeral head moves more closely to the axillary artery and brachial plexus, there is a high risk of neurovascular injury, including axillary nerve, axillary artery, and the brachial plexus. It is also usually associated with significant damage to the rotator cuff tendons. Next, a note on recurrent shoulder instability. This can be grouped into two distinct classes: unidirectional instability and multidirectional instability. Unidirectional usually happens due to previous trauma and labral damage. It happens, as the name suggests, in one shoulder. Bankhart's lesion is a classical pathological finding. Surgery is the standard treatment. Using these, the mnemonic TUBS or TUBS is often used to describe unidirectional instability. The second group, the MDI or multidirectional instability, is atraumatic in nature. It is multidirectional as the name suggests. It is usually bilateral. The key treatment for this type of instability is rehabilitation with physiotherapy. Rarely, a capsular imbrication surgery may be needed. And using these, a mnemonic AMBRI or AMBRI is often used to describe multidirectional instability. Clinically, an apprehension sign is elicited in unidirectional instability when the arm is moved into a dislocatable position. In MDI, patient may be able to voluntarily subluxate or dislocate the shoulder, and they also exhibit signs of generalized ligamentous laxity. As I mentioned earlier, the treatment of unidirectional instability is surgical. In case of Bankart lesion, arthroscopic capsulolabral repair is the treatment of choice. If the glenoid rim is insufficient, reconstruction with coracoid process, also called Latarjet procedure, may be appropriate. Other procedures, such as Putiblat double breasting operation, are largely historical. In case of ambry, occasionally a capsular imbrication may be helpful. Now let's move on to the next section, proximal humerus fractures. A square box that accommodates the widest part of the proximal humerus demarcates it from the shaft. And Neer's classification of the proximal humerus fractures is based on 4 distinct anatomical parts: the humeral head, the greater tuberosity, the lesser tuberosity, and the shaft of the humerus. To be considered displaced, the fracture fragments should have moved by more than 1 centimeter or would have angulated by over 45 degrees. And based on this, it could be a 2-part, a 3-part, or a 4-part proximal humerus fracture. The usual etiology is a fall or a road traffic accident. Sometimes, a pathological fracture can happen due to a metastatic deposit. Here you can see a fracture along the surgical neck of the humerus, and here fracture of the greater tuberosity. Complications associated with proximal humerus fractures are axillary nerve injury. This is due to its close proximity to the surgical neck of the humerus. Malunion is common. It is not normally a disability because a good range of movement is present in the shoulder. Non-union is rare. Shoulder stiffness and adhesive capsulitis and avascular necrosis of the head of the humerus when the fracture is close to the anatomical neck are other complications. Before we wrap up this video, a quick look at the treatment of the proximal humerus fractures. Non-operative management is usually done for a minimally displaced fracture, and this includes a plaster slab application or a collar and a cuff application. However, for a significantly displaced fracture, an open reduction and internal fixation with plates and screws is a standard recommended treatment. Closed reduction and internal fixation with multiple K-wires is another option. Sometimes, for an extensively comminuted fracture, partial replacement, also called hemiarthroplasty, is also recommended. If you have enjoyed this video, please like, share, and subscribe. Thank you for watching.